Okay, so good morning, everyone. I am Carolina, and on behalf of the Informs Diversity, Equity, and Inclusion Committee, I welcome you to this webinar series, which highlight research on DEI-related topics in the areas of ORMS. Today, we have with us Dr. Jennifer Lobo, an Associate Professor of Public Health Science in the Division of Biomedical Informatics at the University of Virginia. Welcome, Dr. Lobo, and thank you for accepting our invitation and joining us today. Before we begin the presentation, there are two things I want you to be mindful about. One, this session is being recorded and is later going to be available at the Informs DEI community page, as well as all the previous and future webinar series. Also, the presentation is going to be around 30-35 minutes, and we will allow some time for questions. Please put your questions in the chat box, and we will discuss them at the end of the presentation. Dr. Lobo, welcome, and the floor is yours.
Great. Thank you so much. Let me share my slides here. All right. Can y'all see my slides okay?
Yes.
Great. Thank you so much. Well, thank you for the invitation. And today I'm going to talk to you about detecting, understanding, and reducing diabetes belt preventive care disparities. This is a multi-year project, so I'm going to present some results that we have and then some ongoing work that we're doing. This work is a collaboration with my colleagues listed here, and the co-PI of this work is Dr. Min Wong Son. This work is supported from the National Institute of Diabetes and Digestive and Kidney Diseases from the NIH, and we have no conflicts of interest to report. So first, I want to go into some background about the diabetes belt and preventive care within diabetes patients. And then I'm going to present some of our findings as well as ongoing operations research methods that we're using to understand and hopefully address disparities that we're finding. And then at the end, I'd love to have a discussion about the role that operations research methods can have in reducing disparities. 34.2 million people in the US have diabetes, and it affects about 1 in 10 Americans. And about 20% of these patients don't know that they have diabetes. The diabetes belt is similar to like the stroke belt that you've heard about. It's an area of 644 counties in the southeastern and Appalachian regions of the United States, shown here in maroon. And this was first identified by Barker et al. In 2011. These counties were chosen given their greater than 11% prevalence of diabetes in 2008 when it was first identified. And this region continues to have high prevalence of diabetes today. They also have higher rates of chronic conditions and higher mortality rates that goes along with this higher prevalence of diabetes. For comparison, in our studies, we also considered the surrounding counties. This was 118 counties shown here in light green. And this was not contiguous to the belt. We excluded the counties that were immediately adjacent to the belt from our definition of surrounding counties to reduce the potential confounding due to boundary crossing for healthcare seeking. People with diabetes are at higher risk of many serious health complications. Those include blindness, kidney failure, heart disease, stroke, and lower extremity amputation. These are serious, mostly irreversible complications for diabetes patients. So it is imperative that patients utilize preventive care. Our hypothesis is that the patients in the diabetes belt may have lower rates of preventive care utilization, leading to higher prevalence of chronic conditions. The preventive care shown here on the right are a subset of the American Diabetes Association guidelines for preventive care. And the work I present today will focus on the utilization of these A1C testing, foot exam, eye exam, and microalbuminuria testing. So here I've presented our overarching objectives of our larger project. The first set of results I present are going to be related to AIM-1. And here we want to determine utilization rates of the guideline preventive care services that I outlined and examine factors that affect that utilization. Then I'm going to highlight the operations research methods that we're using in our work to further understand and identify policies that can reduce disparities. So first we'll look at the data and development analysis approach to evaluate efficiency of the counties, and then we'll look at Markov decision process models to optimize use of health resources and policy initiatives to reduce disparities. So our project uses Medicare data over a 10-year period from 2006 to 2015. And we included in our sample Medicare fee-for-service beneficiaries with diabetes age 65 or older. We use outpatient and carrier claims data to identify preventive care utilization. And we sampled approximately 900,000 patients each year. There's a very thoughtful sampling strategy used to oversample minority populations to allow for more robust estimates, for example, for non-Hispanic Black patients. And our sampling strategy also allows for both longitudinal and yearly cross-sectional analysis. So we have a technical report that is a working paper that we're gonna try and publish that I can send you for more details about this sampling strategy if you're interested. We also used other sources of data, such as the area health resources files for availability of services within counties, and then the American Community Survey and Distressed Community Index were used for socioeconomic status markers. So I'll go through a series of studies here that we've been working on. And the first study I present here is going to investigate the preventive care utilization among patients in the diabetes belt and the surrounding areas. And this work was led by my co-PI of the study, Dr. Min-Wong Sun. So in constructing models for explaining preventive care seeking behavior, we used the Kilbourne et al. Model, which was partially based on the Anderson's behavioral model. This Kilbourne model included 3 groups of factors affecting preventive care utilization. And of note, instead of the illness or need characteristics of the Anderson model, the Kilbourne model used reinforcing factors to explain preventive care utilization. These are the factors that induce or encourage use of preventive care. So in this study, we identified and used several reinforcing factors, including what we call annual wellness visits, which I'll go into more detail in a little bit. So here are the descriptive data for the sample that we used. We used a probability sample of about 900,000 Medicare beneficiaries, and then these numbers presented here are all weighted numbers. The population in the diabetes belt and the surrounding areas are almost equal in size, and they are pretty well matched in terms of age and sex. There are significantly more non-Hispanic Black patients in the diabetes belt than in the surrounding areas. And the diabetes belt is much poorer in access to primary care physicians, podiatrists, and eye doctors. And of note, many rural counties had no podiatrists or eye doctors at all. Here are our main findings from this analysis. So we see here that the utilization rates are significantly lower in the diabetes belt than the surrounding areas. The largest disparity was for the utilization of foot exams. And the preventive care with the least disparity was with A1C testing. So these results held for the unadjusted and the adjusted versions. If we look into more detail at the foot exam utilization, so here we see the unadjusted results as well as different models where we controlled for different demographic factors and other factors. So when we first control in model 1 for the demographic factors, there's still large disparities. Almost none of the disparities are explained by the demographic factors. With model 2, we included zip code level education in terms of percent high school graduation and median household income. These 2 socioeconomic factors accounted for almost 20% of the differences in preventive care use. With model 3, we included access to care factors, including availability of primary care physician and other care providers in the county level. And these additional factors explained about 10% additional differences in the preventive care utilization between the diabetes belt and the surrounding areas. The models for the other 3 preventive care services all showed a really similar pattern that we see here with the foot exam use. So these results found that there was significantly lower utilization of preventive care in the diabetes belt compared to the surrounding areas for all 4 services. So this is part of our detecting phase of our research. The largest disparities were found for foot exams and the smallest for A1C testing. And we found it interesting that socioeconomic factors appear to explain a large amount of the disparities. And so we're looking into this finding more. But one interpretation might be that the awareness of the ADA guideline recommendations and the importance that they have in preventing diabetic complications may be an important factor in the prevention of these events and actually having the patient seek out this preventive care. So in the community, we've long known that the uptake of preventive care is suboptimal in general. And so the goals within Healthy People 2020 and now Healthy People 2030 have had this as part of the objectives. Reduction of disparities in healthcare utilization and outcomes has also been an important policy goal. However, we see that there are still are disparities that exist, and there appear to be lack of consistent and focused policies that are helping reduce these disparities, especially within the diabetes belt. So more targeted policies are needed to improve preventive care use within the diabetes belt. So I'll move on to a related study here that's focusing on the role of annual wellness visits for preventive services utilization. So annual wellness visits were introduced for Medicare beneficiaries in the Affordable Care Act. So this benefit began 10 years ago on January 1st, 2011. And annual wellness visits are covered once every 12 months for Medicare beneficiaries. They're used to develop or update a personalized prevention plan to help prevent disease and disability. The plan is supposed to take into account the patient's current health status and risk factors. They're individualized to look at personal and family history. They hopefully will link the patient to care by creating a screening schedule for appropriate preventive care services, including flu shots and then other diabetes-specific preventive care if the patient has diabetes. So our research question with this study was, are annual wellness visits associated with preventive care utilization among patients in with diabetes in the diabetes belt? So here we used a case control study design, and outcomes were the utilization of preventive care services, and the exposures were the utilization of annual wellness visits in the previous year. We defined cases to be the patients who received the service and controls to be those who did not. And the event date for cases was the first date in 2015 on which the patient received the service. And for the controls, that event date was defined as the last day of 2015. So in this example depicted here, we have the patients that had a foot exam and an eye exam during 2015. And the annual wellness visit occurred in 2014 during the year prior to the foot exam. So here I've got in the left table the demographics by whether the patient had an annual wellness visit or not in 2015. And overall, we see that the rate of 17.4% of annual wellness visits was very low. This is up from like 13.6%, I believe, in 2014. So even about 5 years in, the rate of annual wellness visits was suboptimal. So in this research, we used the propensity score stratification. And after propensity scores for using annual wellness visits were computed, we used them to divide the sample into quintiles, and 5 weighted logistic regression models were separately estimated, with weights being sampling weights. The estimates and standard errors were averaged to produce one set of estimate per outcome, as shown in the table on the right here. So overall, we see that the odds of receiving preventive care are significantly increased for patients who've had an annual wellness visit. So in particular, I want to point out that for foot exams, we have the largest increase in those odds. So a really strong effect for those patients who have had an annual wellness visit in terms of getting a foot exam. Given that annual wellness visits appear to be very effective, we feel that they should be specifically targeted to high-risk populations, such as those patients in the diabetes belt. So for our next portion here, given that we found that the large disparities in foot exam use and that connection between annual wellness visits and foot exams, we wanted to take a closer look at the major lower extremity amputation rates in the diabetes belt and surrounding counties over the 10-year horizon. And this is related because if patients have foot exams, they're going to be less likely to need amputation later in life. So we have a sample of around 900,000 Medicare beneficiaries each year, and we use these patients' outcomes to compute the number of unweighted major lower extremity amputation rates in the diabetes belt and the surrounding counties. So here we have in blue the diabetes belt values and in orange the surrounding values. The diabetes belt consistently had approximately one additional MLEA per 1,000 people than in the surrounding counties over the entire 10-year horizon. And we do see a decrease in those rates over time. Surprisingly, we don't see a major change after the 2011 effect from the Affordable Care Act. When we break this down further, we see very large disparities between the non-Hispanic Black patients here in the close dashed lines and the non-Hispanic white patients in the more spread out dashed lines. This is true for both the belts and the surrounding areas that we see these disparities. These findings underscore the importance of looking at results for subpopulations to identify where the disparities exist. So if we hadn't looked at this by race, we would have just seen some more minor disparities in terms of geographic area. But now that we looked at it by race, we are actually seeing these really large disparities do exist. So these were the unweighted results, and we found the same disparities by race and geographic area with the weighted results. So the findings from this study show persistent disparities in major lower extremity amputation rates between the diabetes belt and surrounding counties. And although there were declines in the amputation rates over the 10-year horizons, there was a large gap between the rate for non-Hispanic Black patients and non-Hispanic white patients throughout the 10 years. This gap between the Black and white patients was larger among patients in the diabetes belt than those in the surrounding counties. We found that our results are consistent with other results in the literature and provide additional information beyond what is in the literature. Namely, we looked at the diabetes belt area specifically and those racial disparities in amputation rates as well. We really feel that in particular for the non-Hispanic Black patients, there need to be targeted policies to help eliminate these racial disparities. All right, so now I'm going to move into looking at highlighting the operations research methods that we're using. So here we want to further understand the disparities that we're observing and look at how we can move towards identifying policies that would help reduce the disparities. So we're moving from our detecting phase into our understanding more at the county level, and then also ultimately hoping to reduce the disparities. So the first method I'm going to talk about is data and development analysis. And this part of the work is led by our collaborator, Dr. Hyojun King. And so first I'll go into a little bit of background about data and development analysis. So DEA is a non-parametric method used in operations research and economics, and it measures the relative efficiency of decision-making units, or DMUs, by calculating the ratio of the weighted sum of its outputs to its inputs using a linear programming model. DMUs are any production unit, such as banks or shops or hospitals, which consumes inputs and produces outputs. So this method is often used for benchmarking, and a set of efficient DMUs can serve as a best practice frontier. And so we can understand the characteristics of the efficient DMUs and understand how inefficient DMUs might change their behavior to become efficient DMUs. The main advantage of this technique is that one, it can handle multiple inputs and outputs, so we don't have to just constrain ourselves to a single output, for example. And then we can also identify the sources of inefficiency for each inefficient DMU. So efficiency scores range from 0 to 1, with 1 representing an efficient DMU. So we'll look at the next slide with, and a couple slides with some results, so you can keep that in mind. So for our project, we're defining the decision-making units as counties or groups of counties called core-based statistical areas in the diabetes belt and surrounding areas. We initially planned to use just counties as our DMUs, but we found that there were a lot of patients that were leaving their own county to seek care in another county, and that was becoming pretty challenging for looking at efficiency at the county level. So we moved towards a hybrid of DMUs between counties and these core-based statistical areas that are based on census information. And so hopefully patients within a CBSA are going to live and seek care within that CBSA, making it a reasonable DMU choice. The inputs for our DA model are the number of primary care providers and nurses. And then the outputs are related to preventive care. So in this case, we looked at annual eye exams, annual foot exams, annual doctor visits with diabetes as the reason for the visit, and then 1 or more A1C tests in the past 12 months. We use an output-oriented DEA model, and here that means the goal is to maximize the level of output given the level of inputs. So here are our preliminary results for our DEA model. The efficiency scores are depicted by county here. So in the green, we have the individual counties, and then the orange are counties that are parts of CBSAs. The darkest colors represent the more efficient counties, including those on the efficient frontier. And the lighter counties are going to be those that are less efficient. So we're currently working on identifying characteristics of the efficient counties, as well as the sources of inefficiencies for those that are inefficient counties. And so one thing, looking at it in geographically like this, we can see relationships between the CBSA counties and those individual counties. There's some clumps that are inefficient counties, and then other clumps where you have efficient counties of different types. So we're going to look more into those relationships, those clusters as well. And then after that, we plan to look at the changes in efficiency over that 10-year horizon that we have data for. We have recently published related work with DEA for counties beyond just the diabetes belt. So this was while we were waiting for our Medicare data to come in, we used breakfast data for counties around the United States beyond just the diabetes belt. And these results showed that over half of the counties in the analysis were inefficient. And then foot exams and eye exams were often identified as sources of the inefficiency within this analysis. I'd be happy to share this work if you'd like a copy of our paper. And then the last part of our project within AIM-3, it will be the Markov decision process model. And the objective here is to develop an optimal plan for using healthcare resources and policy initiatives to reduce disparities in preventive service utilization and rates of diabetic complications within the diabetes belt. The states within our MDP model will be county level efficiency states as well as individual level health states. So it'll be a hybrid county individual level model. The actions that we will have are implementation of healthcare policies and resource allocation decisions. And then the probabilities that we need to estimate are coming from both AIM-1 and AIM-2 work. So within the AIM-1 work, we're going to be estimating probabilities related to preventive care service utilization and the probabilities of complications. And then the AIM-2 work will be used to estimate probabilities among efficiency states from our longitudinal DEA analysis scores. So we plan for our experiments to determine the optimal way to use county resources. So within our data, we also have local health department information from NACHO saying how counties choose to use their resources for preventive care and other services. So we're going to look at whether diabetes preventive care provided by local health departments will influence the rate of preventive care. And then we also want to look at incentive programs, including larger uptake of annual wellness visits and some other programs through the Affordable Care Act. The objectives that we're going to look at are going to be minimizing costs of programs and patient treatment, including the care that they receive, as well as the treatment of complications. We also want to look at maximizing the percentage of patients receiving guideline recommended preventive services. And then we'll look at a combination of these objectives. So we want to maximize guideline compliance, subject to budget for these costs that we have to expend. We also want to estimate the effects of removing racial and geographic disparities. So if all patients were able to seek care at the same rate as the patients in the surrounding areas that are white, what would that look like in terms of complication rates? And then we want to also test other hypothetical policies that we could implement in the future based on what we find in the literature that is being explored. So I wanted to show some images that I was actually explaining this to my 3-year-old daughter over the weekend. And I feel like it's nice that a 3-year-old can understand it, but it's a really complicated topic. So within research, we may only see part of the picture. We might see this friend that's able to get an apple. Looks pretty easy to get the apple. If we zoom out though, we might see that there's actual inequalities that are existing. So it's important to identify the inequalities that exist among subpopulations. So here we have seen the geographic disparities within the diabetes belt compared to surrounding counties, and then the very large racial disparities for the major lower extremity amputations. Once we've identified inequalities, it's important to come up with recommendations for how to address inequalities. So it's not enough to give patients the one-size-fits-all approach to these tools. So here we've given each of the friends a ladder, but one still doesn't have enough access to the apples. And then, so we see that the tools and the policies must be tailored to the individuals to actually address the inequality to reach equity. So we need customized tools to address the inequalities. And beyond the customized tools that address those inequalities, we must understand the systematic issues that are causing these inequalities in the first place, and ultimately fix the system itself so that all patients will have equal access. I know a lot of you probably attended the Informs Healthcare conference last week, and we were able to hear from Dr. Corby Smith about the importance of innovation, systems thinking, and transdisciplinary research. And she noted that if one discipline could fix health equity, it would have already been fixed. I wholeheartedly agree with her that OR practitioners and researchers can play an important role in multidisciplinary teams in identifying disparities and helping determine policies to make healthcare more equitable. And so I think that's a really good call to action that we have here, right? That we can continue to help with this really, really important problem. So thanks for your attention, and I welcome your thoughts and questions that you might have.
Thank you, Dr. Lobo. Was a really nice presentation. The last part made me think a lot how we put things in context and how we can actually take actions into the things that we see or the research that we do. So I'm really excited about seeing this. So I'm gonna open the floor for questions. You can type a question in the chat, or you can unmute yourself and please ask your questions or raise your hand. Okay, so I'm gonna start with the question. So when I think about diabetes belt, sometimes I always think about food and the quality of food. So on the data that you look at, do you find any correlation with the area, if it's a food desert area, or if the access to good quality of food has a correlation with the rates on diabetes?
That's a really good question. We don't have information included so far about food deserts, but I think that's something we could definitely look into to see if that's playing a role. You know, we have the patient's socioeconomic status, so that could kind of be a surrogate marker for that. Potentially, that's included under that umbrella. So yeah, thank you for that suggestion, but we haven't looked at that explicitly.
Thank you. And I have one more question, unless someone wants to jump in and ask. I'll give you the floor or the microphone or the screen. Okay, so my second question is, on one of the slides, you show, there was a number that really surprised me. So the people in rural areas, they only, I think 4.6% had access to annual wellness visit. You know, what are the challenges they face to access to these services? It is a transportation issue, how far they have to go, or is there many other reasons related to that?
Is it the slide you were talking about here?
Yes.
Yeah, so this has been interesting. We haven't fully looked into this question, but we did notice that so I think it was around 13% of patients in 2014 had annual wellness visits among the diabetes belt and surrounding counties. And here is the 2015 data, goes up to 17.4%. We're hoping to do a follow-on study where we get more Medicare data past 2015, where we can see how this changes over time and hopefully continues to increase. As far as the reasons for the low rate of annual wellness visits, one, I think there's an education issue with, you know, either educating providers or educating patients that this isn't a benefit that they have now, that they need to take advantage of, and that how it can help them. But I definitely think that things like transportation that you mentioned are a factor. So this is kind of like an extra visit that patients might have to come to. Even though these patients might be retired at 65 years or older, they often live in rural areas within this region. So transportation can be an issue. Just having enough providers to treat the patients in the area can be an issue. So access in general is a big issue that we also see with this population.
Yes, because that made me think of the reflection you did at the end. This exam is free. They don't have to pay for this. So there is already the opportunity to have that access. But then I was thinking where these clinics are located. So if it is close enough to reach to the larger population, or what are we doing wrong that just we benefit those who are in the cities? What about the other side of the coin? So that number, I was thinking 4.6%, that's low.
Yeah, and we definitely have like looked at the geographic areas a little bit more in terms of how many providers are within 15-minute drive of the centroid of the patient zip code. We can't get their exact address to see how close they are. So yeah, there is a lot of like variation in terms of how many providers are within that 15-minute area. You know, some zip codes have, you know, over 50 providers in their area, and others are one or two. So there's a lot of variability there,
yes,
which can cause a lot of challenges with access for sure.
Yes, it's an interesting problem. Let me ask again if someone else have more questions. I'm excited about the topic, so I can keep asking questions, but I don't want to take time from all of you. So if you have questions, please free to do it. I'm going to keep a couple of seconds if anyone wants to ask something to Dr. Lobo.
Dr. Lowe, this is Gina. Did they do any study on mobile healthcare? I know that same region had like dental mobile and had great success with it.
Yeah, so we haven't looked at that with this project in particular. Another project I work on with looking at bladder cancer patients and screening for recurrence of bladder cancer, we've looked at more efforts to bring care to the patient. If they have to travel for specialty care, bringing the care to their local clinics via telemedicine can definitely increase the compliance with that follow-up. So I would imagine something similar would be here. So this was in Southwest Virginia that I'm mentioning for this other project, where it's a very rural area, part of the diabetes belt. So in general, I think that's a good approach, bringing the care to the patient, meeting them where they are, trying to remove as many barriers as possible.
Thank you. So someone else have a question, or I'm gonna have the chance to ask my last question. Okay, so this is a two-part question. One is on the study, you mentioned a lot of socioeconomical factors. Do you consider any behavioral factors? I think in diabetes, a lot of the reasons someone can develop diabetes are as a consequence of bad habits or behavioral factors. Do you consider those behavioral factors maybe in the area if there is not too much access to education that can contribute to not being aware of what type of food you should eat or what is going to be more healthy for you?
So we haven't looked at like access to parks or, I guess advertisements for sugar sweetened beverages, things like that. We haven't looked at that level of detail within the counties. That's another good suggestion along with the food deserts. I think that those are definitely factors that can contribute to them having diabetes in the first place and then how they manage it. But yeah, that's a good suggestion. Thank you.
And my last question to end is, what do you think as ORMS researchers we can do to showcase or bring some awareness on DEI research?
Yeah, so I think I found, since being in the School of Medicine, partnering with other practitioners that are of other backgrounds is really important. So partnering with doctors, statisticians, other types of workers, is really important to have this understanding from our perspective of the medical challenges that patients face, the reasons they face those challenges, and then educating our colleagues on our methods and how we can contribute to these problems and helping find solutions and modeling what those solutions might look like in a population. So just highlighting what those benefits are that we bring to the table to colleagues. I found it can be challenging to find colleagues that are open to these kinds of methods. So my tip that I give people is to find people with an MPH, because usually Master in Public Health doctors are more open to quantitative methods, simulation methods that they might have been exposed to in their coursework. So I think working with those colleagues can be really powerful.
Well, thank you so much, Dr. Lowe, for your time. I think that was a really great advice. I think it's great if all of us as researchers, we can build our own network of people that focus on the same objectives and kind of fight for DEI. So I think that's a great advice, and I hope everyone can create their own network or be part of a network of change. So I'm going to share my screen one more time to invite everyone to our next webinar series. So we are going to be talking about an introduction to Black power, improving health, wealth, and power in Black communities. Remember to register. You can do that by going to the Informs DEI website. Thanks everyone for your time, and thank you, Dr. Lowe, for your time and the research you shared with us. Hope to see you again and see you everyone on our next session. Stay safe and healthy.